بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is a short lecture about imaging of the post-operative spine. I will explain here, inshallah, some of the important issues about evaluation of the spine in the post-operative days. And you know that evaluation of the spine after surgery is usually performed 8 weeks from the date of surgery in order to be sure that most of the post-operative changes have been regressed and the accurate evaluation of complications can be performed at that time. Then you know that one of the most common operative interventions in the previous days was this kind of surgery, which is known as spinolaminectomy, where you can remove part of the left lamina and also part of the right lamina together with the spinous process, and you remove this segment so that you can release the posterior aspect of the cecal sac, and then you can decrease the pressure or the mass effect of the disc on the cecal sac as well as on the nerve root. And you know we have two ways for evaluation of the spine post-operative. These are the CT scan and the MRI. In the era before MRI, we used to use the CT scan as the only available tool for evaluation, and in the evaluation we used to inject the patient with contrast intravenously after having a pre-contrast study for the affected segment of the spine. In the lumbar spine is frequently we use this injection of contrast medium, whether for CT or for MR examinations. I have mentioned the importance of this dynamic MRI in evaluation of the spine before surgery and after surgery. As you can see in this example, that this patient had an operative intervention at the level of L4-5 and maybe L5-S1. He is still complaining, but the supine or the recumbent MR examination showed that there is no evident postoperative complications. But whenever we examine the patient in the erect position with some axial load on the spine, there is a definite abnormality at this level. Then you can see there is a significant spinal instability with a spondylolysis of L3 over L4 and deformity of the spinal canal at that level. Then this study was also performed before surgery, and this is the recumbent MRI and this is the erect MRI. Then you can appreciate the difference between both scans, where in the upright position there is some retrolysis of L5 over S1, and there is also a prominent disc lesion at L5-S1, which was not appreciated very well in the recumbent position. Then the aim of imaging of the spine after surgery is mainly to detect if there is any postoperative complications or not. In the early days of MRI and also the days of CT, where the major surgery was performed, or the most common surgery performed was the spinal laminectomy. We were interested to identify the site of surgery, which was very important as a medical legal issue, and also we was interested to state in the report if the cecal sac is adequately decompressed or not. But in the current days, where the minimally invasive surgeries are in common use, we do not need to have these two comments, but we are interested now to look at if there is any post-operative complication. And the surgeries, as you can see, we have too many types. The first one was the spinal laminectomy. As you can see here, we remove part of the lamina on the left and part of the lamina on the right together with the spinous process, and we leave the posterior aspect of the spinal canal open, as you can see here, and the cecal sac is adequately decompressed. Then the second type, and this is also spinal laminectomy. In the previous days, this was an extensive spinal laminectomy from, let's say, L2, 3, 4, 5, and you can see absence of the spinous processes compared to the normal spine, where you can see these are the spinous processes normally located in the midline. But whenever you remove the spinous process as well as part of the lamina, you can see that the posterior aspect of the spinal canal is widely opened. The second type of surgery is to remove only one of the laminae, what's known as hemilaminectomy, as in this example. You see that the right lamina is missing while the left lamina is there. And this was indicated whenever there is a disc herniation to the right side, then you remove the right lamina to attack the disc, or if the disc is located on the left side, then you may remove the left lamina. The third type of operation was just a fenestrotomy or laminar fenestration. You do an opening in the lamina. You do not need to remove the whole lamina, just to have an access for the site of the disc lesion to be removed. Then this is an example of laminar fenestration, and you see the defect in the right lamina. You can also appreciate the deformity of the cecal sac corresponding to the site of surgery. Then recently we have what's known as minimally invasive surgery, where you do not remove the lamina, you do not remove the spinous process, you don't have to remove a single lamina or even to do a fenestration in the lamina. All what is done is just to remove part of the superior surface of the lamina on both sides, so that you are able to go inside the spinal canal and to remove such a big disc. Then whenever you have imaging, you will see that the lamina is intact on the left and on the right, and also you can appreciate the existence of the spinous process, because all what has been done is just a removal of the superior aspect or part of the upper aspect of the lamina on both sides, so that you can be able to get inside the spinal canal. Then after removal of the disc, there were many processes to be fixed at the site or instead of the removed disc. And by time they discovered too many complications of these processes, and they started to change the type and the shape of the processes itself in order to avoid these complications. And here is one of the complications where the disc spacer or the disc cage has been let's say indented progressively the superior aspect of the vertebra below, ended by this very bad configuration at the level of surgery. Then there are other devices that may have some size, and they are broad so that they can conform to the edge of the vertebra above and the vertebra below. And many times you can fix this device into the vertebra above and the vertebra below. And also, this is one of the examples of disc spacers or disc prostheses. They tried here that the prosthesis can move to simulate the original disc, because you know that if you have fixed this level, there is a great opportunity to have a disc lesion above the fixed level or below the fixed level. Then they tried to have a disc spacer which can allow some movement at the level of surgery, so that you can prevent the development of disc lesions above or below the level of surgery. Then what are the expected post-operative complications? These are number one, the post-operative scar tissue formation, recurrent disc space infection, and arachnoiditis. And MRI is more better than CT scan in evaluation of post-operative complications. So if anyone is going to have surgery on the spine, he should have a preoperative MRI in order to have a baseline for comparison after surgery. And then the post-operative scan for this patient, and you can see that there is surgery here, and this is the cecal sac, and this is the nerve root surrounded by epidural fat on the normal left side. But at the site of surgery, you cannot see the nerve root, and you see a shadow which may represent a post-operative scar or a disc herniation or both. Then you have to inject contrast media, and you know that the scar tissue will enhance with contrast media while the disc will not enhance. Then after injection of contrast medium, you can see that the whole lesion has been enhanced with contrast, denoting that this is a post-operative scar tissue. And you see that there is a spinal laminectomy with the cecal sac is decompressed, sagging through the laminectomy defect. Actually, within the enhancing scar tissue, you will identify the nerve root. And this is, of course, the nerve root, because on the opposite side, you have the corresponding nerve root. And you should know also that the nerve root which is entrapped within the fibrous scar will not look as similar to the normal nerve root. It will be swollen and may show some contrast enhancement. Then in this example, and you see a shadow here, and you want to know if this is a scar or disc, then you inject contrast media, and you have enhancement of the whole lesion, leaving the nerve root inside, and this is what we call perineural scarring, which was surrounding this S1 nerve root. The nerve root, as I have said, will not look similar to the normal one. It will be slightly swollen and may show some contrast enhancement. In this example, you see a shadow here on the left side. After injection of contrast, this shadow is enhanced, denoting that there is epidural scar, and if there is a nerve root here, there is also a perineural scarring. This was the CT scan performed in cases of postoperative spine. And this patient, there is a laminar fenestration on the right side, and this is the cecal sac, and this is of course the nerve root, which is surrounded or entrapped by the extensively enhancing perineural scarring. In this case, you see this is spinal laminectomy, and there is a big defect in the posterior aspect of the spinal canal, and this is the cecal sac, and you see a big shadow here. Then you inject contrast median, and you can see easily that this shadow represents a postoperative scar, and there are two nerve roots, and this is the cecal sac, which is decompressed at the laminectomy defect. Then in this example, axial T2 weighted image, and you see a lesion here. This may represent disc or may represent scar tissue or both. Then after injection of contrast, you see that the periphery of the lesion is enhancing, representing the scar tissue, while the central part of the lesion is not enhancing, representing the disc lesion. Then this is a recurrent disc with postoperative scar tissue as well. And in this example, and you see this lesion, which is migrating cranially. After injection of contrast, the periphery of the lesion is enhanced, denoting the presence of scar tissue, while the central part of the lesion did not enhance, denoting the presence of a recurrent disc herniation. Then you remember that arachnoiditis means inflammation of the arachnoid membrane, and the most two common causes are trauma and surgery. Inflammation of the arachnoid membrane will lead to adhesion between the nerve roots, the coda equina nerve roots, each other, or adhesion between the nerve roots and the inner wall of the cecal sac. Then if the nerve roots are adherent together, they will form a mass inside the cecal sac, and this mass is called the pseudocord sign because it almost simulates the spinal cord, where, as you will know, there is no spinal cord downward in the lumbar spine. This is the normal appearance of the coda equina nerve roots in the axial T2 weighted image. They are usually located posteriorly because the patient is lying on his back. And in cases of arachnoiditis, you cannot identify the nerve roots inside the cecal sac because they are adherent to the inner wall of the cecal sac, and this is what we call empty cecal sac sign. Then you may have the pseudocord sign if the nerve roots are adherent together, forming a shadow inside the cecal sac, which may simulate the spinal cord. And the empty cecal sac sign means that the nerve roots are adherent to the inner wall of the cecal sac, leaving the rest of the cecal sac as if it is empty. And this is a case of arachnoiditis, and I should remind you that don't diagnose arachnoiditis in the sagittal images because the patient is lying on his back and the nerve roots are usually collected together in the posterior aspect of the cecal sac, and you cannot discriminate in many cases the difference between normal nerve roots and nerve roots secondary to arachnoiditis. But in the axial image, it is easy to see the nerve roots that are clumped together or adherent together inside the cecal sac, forming what's known as the pseudocord sign. And many times, or some of the investigators may want to inject the patient with contrast if arachnoiditis is suspected, and this is an extensive case of arachnoiditis where you can see extensive enhancement of the cecal sac and coda equina nerve roots that are adherent together, almost forming a very big mass inside the cecal sac. Then in the days of myelography and CT myelography, these are the two signs, the pseudocord sign and the empty cecal sac sign, and they are almost similar to the findings seen by MRI. Here is the normal appearance of the coda equina nerve roots, and this is what we call the pseudocord sign, where the coda equina nerve roots are accumulated together, forming a mass which is similar to the spinal cord. Then disc space infection can be due to biogenic organisms and other causes, as I have explained in details in the lecture of spinal infection. But in cases of postoperative spine, you got sometimes biogenic infection at the level of surgery, and this will be similar to the biogenic infection without surgery. There is involvement of the disc space with bone marrow edema of the superior end plate as well as the inferior end plate, and by time you got narrowing of the disc space, and finally you can see some collapse at the level of the affected disc. Also you can see paravertebral and prevertebral abscesses, which are not common in cases of postoperative spinal discitis. And you remember that the most common organism to cause biogenic infection is the staphylococci, and this is an example. You see, without surgery, you see the disc is inflamed. It shows high signal in the T2 weighted image with extensive bone marrow edema of the vertebra above and the vertebra below. And you remember the difference between bone marrow edema secondary to degeneration, which represents type 1 degenerative changes, and bone marrow edema secondary to infection. In cases of degeneration, the disc space is narrowed, and what's very important is the appearance of the disc in T2 weighted image. The disc will be black because it has lost its water content. But in cases of infection, the disc will be very bright because it is full of water and inflammatory granulation tissue. Then, whenever the disc is inflamed and you got relative narrowing of the disc space and bone marrow edema of the opposing vertebral end plates, in the T2 weighted image, you will see very bright signal, the signal of fluid inside the disc substance. And here you can see two levels of discitis or disc space infection at L4-5 and L5-S1. And if you inject contrast medium, the inflamed disc as well as the inflamed vertebral bodies will enhance. And you should remember that bone marrow edema of whatever etiology will enhance with contrast medium. Then if the disc space infection is going to heal, and you will see the development of some bone sclerosis at the vertebral end plates above and below the affected disc. And you can also see that the brightness in the disc substance secondary to infection is regressing. And also, if you inject contrast media, you may see some enhancement at the level of the disc lesion. And if there is granulation tissue, the granulation tissue will be regressing as well. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.